Yeah, I guess we shall begin our webinar. So, good afternoon, everyone, for joining. Welcome to our weekly webinar organized by College of Physicians Malaysia. Theme of the month is geriatric medicine, and we are very lucky to have Dr. Elizabeth Chong with us today. Dr. Elizabeth Chong is a consultant geriatrician at Hospital Kuala Lumpur. She serves as the lead for the National Falls Prevention and Intervention Steering Committee and spearheads the Auto Geriatric Services under the Ministry of Health Malaysia. She is also one of the key driving force behind the development and implementation of Malaysia's National Geriatric Fracture Liaison Service Policy. Dr. Elizabeth has played a pivotal role in the development of numerous national healthcare guidelines, including the Falls Initiative for Older Persons, the Guideline on the Implementation of Patient Falls Prevention and Intervention Program, the Model of Care for Hip Fracture Management, the Fracture Liaison Service Framework, and the Clinical Practice Guidelines for the Management of Osteoporosis and Geriatric Hip Fracture. Beyond clinical and policy contributions, she is actively engaged with professional societies. She currently serves as the president of the Fragility Fracture Network Malaysia and is a member of the Malaysian Osteoporotic Society. Additionally, she is part of the steering committee for the Southeast Asia, Hong Kong and India Bone Academy and holds the position of deputy chair for the FFN Asia Pacific Regionalization Committee. Her research interests are centered on falls prevention and intervention, osteoporosis, and dementia. Without further ado, let us welcome Dr. Elizabeth.
Thank you very much, Kelvin, for the long introduction. I was just hoping that you just say that, well, I'm a national lead, that's about it. Thank you so much, everyone, for giving us this 1 hour to talk to you about a new that the geriatric fraternity is embarking on. So today our topic will be fracture liaison service, a new policy. It might be a new idea to you. What is fracture liaison service? Have I ever heard of it before? That's why we're here today. So I just hope to keep your interest high. So as a general introduction, fracture liaison service has been introduced internationally starting in the United Kingdom in the early 2000s. It has increased in leaps and bounds in terms of international recognition and acceptance of this policy because it has improved a lot of fracture and osteoporosis management for our patients. So Malaysia, not backwards also, we are jumping on the same bandwagon. We want to join the international fraternity to make our fracture and osteoporosis care better. So in year 2022, we have revised our CPG guidelines for osteoporosis. And in year 2024, which is last year, we have actually launched our CPG for the geriatric hip fracture guidelines. So if you've never seen these two CPG, I would advise that you go and have a look at them. They are newly written, fresh on the market. This is good to know a little bit about it. And there are a lot more initiatives, including we are introducing osteoporosis care to primary care to help us with the management because it is overloading the system in the hospital. And majority of osteoporosis care internationally has actually been anchored in the primary care. So today we are very, very privileged to have Dr. Lim Wan Chair with us, an esteemed geriatrician. So we have worked together for a very long time and currently he is working in Sunway Hospital, Ipoh. He has got special interest in osteogeriatrics and is actually a secretary of the Fragility Fracture Network Malaysia Society. So he does contribute a lot in terms of starting a service in typing for fracture liaison service, and I'm sure he's going to do that now. And he has actually been invited as one of the members who is tasked to write a proposal for fracture liaison service as a policy for the Ministry of Health. So who's the best person to talk about this topic? So this afternoon, I'll pass the time to Dr. Lim. And if you got any question, please type into the chat box. We'll address them at the end of the talk. Dr. Lim.
Thank you for the introductions, Dr. Elizabeth. It's an honor to be able to present again for the College of Physicians webinar. Welcome to Geriatric Month. So I'm supposed to talk on the new fracture license service policy, but I think my talk is going to focus on the rationale as to why we need a policy. And for those who do not are not yet familiar with what a fracture license service is, then we're going to talk a little bit about what the fracture license service is. So I'm going to share my slides now. Right. Okay, so let's begin. Well, by its definition, the way we envision this geriatric fracture license service is defined as a multidisciplinary system approach to manage fragility fractures and to reduce mortality and morbidity, and also to prevent subsequent fractures. So that is what we are going to talk about. today. A little bit of disclaimer before we start. The GFLS policy is currently in development. We have drafted the manual, but it's currently pending approval from the Ministry of Health. So it's not a policy that we are going to execute yet, but it is in the pipeline. Hopefully, after review by the ministry, if it gets approved, then we can start working on the policy. And I think when it comes to us, because this is a College of Physicians Malaysia webinar, most of the listeners will probably be physicians. And as I understand it, there'll be some family medicine doctors also listening to the webinar. We want to talk about the rationale on why there is a need for policy on geriatric fracture license service. And also related to that, what is the role of the physician? What role will physicians play in this service? And so we have to start from the beginning, right? At the heart of it all is what we call fragility fractures, right? Because fragility fractures are the reason why we think that the policy, fracture policy is important in terms of the Ministry of Health. So fragility fractures basically means fractures that result from low energy trauma. And they usually are an indication of weak bones, namely osteoporosis, although they could be a reflection of other pathologies, for example, malignancy or chronic kidney disease, metabolic bone disease. But of course, in certain cases, you call them pathological fractures instead, right? Depending on what the underlying cause is. And fragility fractures basically affect the older adults more, right? And so, and there are certain areas where the older adults are more have the higher tendency to get fragility fractures at. So at the oldest age, group like 81 to 90 years old, very commonly in the females, you get a lot of hip fractures, but the males are not very far behind. And pelvic fractures, wrist fractures, and shoulder fractures. Whereas in the younger age group, most of the fractures will be probably at the shoulder or the wrist. So this is very different from the pattern of fractures that you see in the younger adults. And the main risk for fragility fractures, actually, these two, falls and osteoporosis. These are the main reasons why people get fragility fractures. And we know that, osteoporosis is a disease that's caused by low bone mass and bone tissue deterioration. And that we reach our peak bone mass somewhere around our 20s to 30s. And subsequently, we lose bone mass throughout our life. And in women, there's another event which causes them to lose bone mass more rapidly, and that's menopause. And after menopause, in women, their bone mass goes down rapidly. And this leads to the condition called osteoporosis, which increases fracture risk. Now, the thing that is very important to note here is that osteoporosis is treatable. That means we can institute preventive care to prevent patients that are susceptible to osteoporosis from developing fractures. And related to that also is falls. And again, the pattern in falls is similar with that, as you get older, there is a higher prevalence of falls. Based on our own National Health and Mobility Survey in 2018, we can estimate that about 1 in 7 community-going older adults above the age of 60 years old have fallen or fall in a year. And in these 1 in 7 people that fall, 1 in 7 of these falls actually lead to hospitalization. So I guess the main point that I want to emphasize here is that falls among older adults are prevalent, and they are not trivial events because they can lead to severe injuries and even hospitalization. And of course, fractures are one of the biggest problems with falls, right? So as the incidence of falls increase with age, and as osteoporosis gets more prevalent with age, then we expect also that fragility fractures become more prevalent as one ages. And it's not that patients who come in with fragility fractures will only have it as a one-off event, because once you've gotten a fragility fracture, if the underlying cause, which is falls and osteoporosis, is not addressed, then there is a very high risk of subsequent fractures. In fact, the risk of fractures are highest immediately post-fall period. And so when these risk factors are not addressed, patients will continue getting more and more fragility fractures, and with each subsequent fracture, they get more morbidity associated with fracture event. And usually it culminates in what we most fear, which is hip fractures, because hip fractures are associated with a lot of excess morbidity. So from here, from all these events where patients come in with fragility fractures, they may represent periods of acute stress for them, but it also represents opportunities for us to institute intervention or prevention so that they do not get future fractures. And that is what we call secondary fracture prevention. That is that in patients who have already had a fragility fracture, you prevent them from getting future fractures. And this is something that we don't quite do very well yet. And we said that the most traded complication of fragility fractures will be hip fractures, and hip fractures have big consequences. So there are many estimates out there depending on geography, depending on healthcare setting. So, when we talk about the consequences of hip fracture, there's lots and lots of data that will give you, variable numbers, but you can roughly say that it can cause lots of inpatient mortality, and it can even cause up to like 30% or 1/3 1-year mortality. And more than half of these patients who have suffered from hip fracture cannot regain their pre-fracture mobility. And more than half of them will have difficulty performing essential activities of daily living after 1 year. So hip fractures are associated with a lot of morbidity and even mortality. And throughout the world, actually, not just in Asia or in Malaysia, we know that as our demographic ages, the proportion of all these problems that are associated with aging is going to increase. And so it's projected that in Malaysia, the proportion of the incidence of hip fractures is going to increase about 3 to 4 folds by the year 2050. And when you compare this to the peers in the region, it is the highest projected growth in the region. So this, if it's not already a problem now, it's going to be a very big problem in the future. And so, because they are not benign conditions, falls and fractures are common in older adults and they're not benign conditions and they're associated with morbidity and mortality, then something needs to be done about it. And given how our demographic is aging, now seems to be a very good time for us to do something about this. And so we have done things about it, actually, and that's where Dr. Elizabeth mentioned the CPG on the management of hip fracture and management of osteoporosis is already out, and you can find it online. And I would say that they are pretty good documents when it comes to, because it's been updated with some of the latest evidence, so it's probably a little better than some of the other CPGs that's out there right now. And you should have a look at it if you haven't yet. And also, we have other related frameworks which have also published in the recent years. One is the Guidelines of Pain Management in Older Adults, and also the other one is the Fracture License Service framework by the Fragility Fracture Network of Malaysia. And we have all these things to guide us on how to manage the patient currently. But when you think about it, having guidelines, does it help us to manage the patient better? You need to think about in the sense that about the resources that you need to get, to manage the hip fracture. So hip fracture care actually involves a lot of collaboration because, compared to something like dengue or DKA or an exacerbation of bronchial asthma, there are many other considerations that we need to make. Patient comes in acute pain, you need to manage the pain, you need to stabilize their comorbidities. And then you need to get them ready for operation, which means that you need to manage their comorbidities in the pre-operative state so they are fit to go for operation. In the post-operative phase, you also need to manage complications that may occur and further optimize their comorbidities. And not enough, because then patients will still not be mobile. You still also need to plan for rehabilitation. And subsequently, assuming that we have done all that, we still need to think about follow-up, about preventing future fractures through osteoporosis treatment and falls treatment. So it ends up being, this multiple parties will end up being involved, not just the patient at the center, with a carer, and with all these team members, doctors, occupational therapists, nurses, geriatrician or physicians, the general practitioners. There's just so many moving parts. So when we come up with a policy, a guideline, a CPG, it doesn't gum all this together. It doesn't allow us to move all these many different parts together. We still need something to enhance the collaboration between the team members in order to make it work. And make it work, we should, because there's already many societies out there who recommend that we institute multidisciplinary hip fracture care. There's just so many societies. And orthogeriatrics has already been implemented for decades now, we can say. And so it all falls into these 4 pillars of what we call orthogeriatrics. Number 1 is multidisciplinary acute care. And also number 2 is rehabilitation. Number 3 is secondary fracture prevention. And number 4 is also very important, national alliances. Because if you want to institute pillars 1, 2, and 3, you do need support from the national governing body in terms of policy. And that's why we talk about policy. And in doing all this, I've mentioned before, but traditional models of care do fall short. And we cannot say that our traditional models of care are standardized across all the different hospitals in the country, because there are so many different ways that we are doing this. But, typically we think that the patient with hip fracture will come in and get admitted to the orthopedic ward where they get prepped for surgery. And then, if there is a need, then the physician will be involved ad hoc for referral. And this all is done in orthopedic clinic. And then they get discharged, presumably for further care. But there are plenty of evidence to show that this traditional model of care does not capture the holistic nature of how we should manage geriatric fractures. Because although evidence is pretty sparse, we don't really collect much data, but there is enough to show us that we are not dealing with the hip fractures in a holistic manner. So one proxy or example that we want to give is through osteoporosis treatment. So osteoporosis treatment gap exists in Malaysia. It also exists in other parts of the world, but in Malaysia, we see this in our National Orthopedic Registry in circa 2009, where they have collected about 500 people with hip fractures, and they find that only a very small proportion of them are already on anti-osteoporotic medication. You also see that in our private hospitals in Malaysia. This is circa 2010-2014, where you see that only less than 1/3 of patients after osteoporotic hip fracture in Malaysia get treated with osteoporosis medication. And the mean duration of treatment is inadequate, with only about 1 month plus of treatment for the patients that we recorded here. And also, even in our centers of excellence in the tertiary care hospital in Malaysia, only about 17% of them are initiated on anti-osteoporotic medication. And of this 17%, only about 40% of them remain on treatment 1 year post-fracture. So this is not, we know that we need to do this. We know that we need to institute proper osteoporotic care, but we cannot just pay lip service to it, and we cannot just say that there are guidelines out there that tell us to do this. We need to make systemic changes in order to effect real change. So even among primary care doctors, there's this survey that found that a majority of primary care doctors do agree that osteoporosis is an important health issue, but not many of them, the majority of them, do not feel confident managing osteoporosis, namely because of barriers, either because of lack of access to pharmacotherapy, lack of knowledge, or even lack of access to a BMD machine. So we are working on some of these systemic factors also, to help to encourage the primary care doctors to participate in the osteoporosis management. For example, alendronate, which for a long time has not been being within reach of the primary care doctors because it's not in the category of AKK. We have downgraded to the category of AKK. So in theory, primary care practitioners should be able to begin applying to get alendronate for their clinic and to participate in osteoporosis management. But the point here is that traditional models of care as they exist now are not very useful for us to effect a good change in what we do. So the other way to look at it is in terms of hip fracture surgery. There's plenty of evidence here to show that doing the surgery for hip fractures early may result in reduced mortality. And that makes sense because when a patient comes in with a hip fracture, they start becoming immobile. And if you delay their surgery for too long, complications associated with immobility will set in. And you don't expect the patient to get stronger just because they wait 1 month, 1 week, 2 weeks. They're just only going to get weaker. So in theory, once we have settled or we have optimized the acute condition, and there is a best time, there's a best time window to go for surgery before the patient gets weaker and the opportunity passes. So we can say this, we know that this works, right? We know that this may help to improve outcome, and we want to push for earlier surgery. But the question is, do you have the OT time to do that? And also related to this, can you convince your administrators to give you OT time so that you can perform your surgery earlier? I think this is a very big challenge. We cannot really overcome this on our own. It's good to have some guidance or policy from the top, or if we were to set this as a key performance indicator for administrators, only then maybe we can effect these sort of changes. And patients who present hip fractures are probably some of the frailest, sickest patients you encounter. I may be over-exaggerating, but it's true that older adults who present with hospitals tend to have lots of problems, and I'm going to talk about two of them. One is multimorbidity, and the other is frailty. Multimorbidity is what it sounds like, right? The presence of multiple comorbidities which cause or complicate care of a patient. So take this example, an 80-year-old lady with a right neck or femur fracture post-fall, previously independent, but underlying diabetes, hypertension, chronic kidney disease, ischemic heart disease, atrial fibrillation, knee osteoarthritis, and a previous stroke. And the hemoglobin at presentation is 7.2. And the oxygen is 93% under room air, and she's on oral anticoagulation because of the AF. Now, we want to push this patient for surgery, but patient obviously needs medical optimization. So why is she hypoxic? Do we delay the surgery while we manage this? And since she's on so many drugs, we also need to mind the drug-drug interaction, the drug-disease interaction. And we know that she's at higher risk of complications from this episode. So it makes it more complex, so to say. And to add on to that is what we call frailty. And to put it in simple terms, frailty means that recovery from illness or injury takes longer or is more difficult, and that patients are likelier to develop complications after operations. Not all older adults are frail, but there are a significant proportion of older adults who are frail, and this proportion gets higher with increasing age. And there are many ways that we can say, that to recognize frailty. One of it is by looking physically, at all these things like, feeling slower, weakness, feeling tired, needing more help with tasks like getting dressed or daily activities, or loss of weight without trying, or even the fact that they take longer than usual to recover from illness. But just finding this is like finding anemia. When you have a patient who is anemic, you still need to find the underlying cause and you need to address it. Otherwise, the anemia will not get treated. And so frailty is actually a manifestation of an underlying problem. And here I'm just giving one example. So when we say that somebody is frail because they are weak, right? They have decreased grip strength, right? It could be that it's because they lack emotional or social support for daily activities and they are not encouraged to do daily activities, so they get weaker. If got weight loss, it could be a sign that there is food insecurity, either because they cannot afford to buy food, or it's because they are still paying for their house. And if you've got exhaustion or slow gait speed, it could also be because of reduced social engagement or social participation, and may be a sign that patients are depressed. And if you are not able to self-manage, it may be because there may be underlying cognitive impairment or a lack of exercise leading to sarcopenia. So to look at the underlying factors that cause frailty, we need to look at it comprehensively. And basically, that's the concept of comprehensive geriatric assessment. And perhaps you've heard of this term on and off, but when it comes to the geriatric medicine, it basically means that you need to look at the patient through multiple dimensions in order to identify pertinent issues that can be addressed in order to optimize patient outcomes. And because patients who present with hip fractures are probably the most frail out there that you can encounter, it is probably proper perhaps that these patients may need this comprehensive way of assessing them when they present to the hospital. And so let's go back to what the GFLS is or was conceptualized as. Is a multidisciplinary system approach. So this system approach, the term here is pretty important. It means that we want to change the system, right? And we want to make it a multidisciplinary management. And our objectives is to manage fragility fractures. That means the acute care of the fragility fractures, make sure that when they come in with fracture, they go home in a relatively good state. Reduce morbidity, because we don't want just to fix the fracture, right? We want to make sure that after fixing the fracture, they regain some sort of function, right? That is rehabilitation. And reduce mortality, because we know that hip fractures are associated with a lot of mortality. And we also want to prevent subsequent fractures, what we call secondary fracture prevention. That's how we conceive it to be. And in terms of the policy itself, we propose that these are the objectives of the program: to provide an efficient and high standard of care for fragility fracture patients for better outcomes in these individuals, and to improve diagnosis, long-term treatment, and decrease morbidity and mortality from osteoporosis. And this is our policy statement actually, that geriatric hip fracture will prioritize and manage through the FLS multidisciplinary care continuum. And perhaps I want to add here, besides reaching good standards of care, which we can achieve through standard care centers of excellence, we also want to achieve a degree of standardization to make sure that, even any center that we go to reaches a certain standard, and then we can be assured of a certain level of quality when a patient comes in with hip fracture to the government hospital. And we want patients with hip fracture to have a definitive fracture management within 48 hours of admission, and that all patients should receive multidisciplinary management from admission till discharge and follow-up. And prevention of falls and secondary fracture is of paramount importance. And these are the key components to the program. Number one is identification of patients with fragility fractures. Number two is a prompt comprehensive assessment and management by the multidisciplinary team. And number three is individualized care based on the considerations of stabilization of acute and comorbid conditions, operation type, prosthesis, resources available, and accessibility to rehab services in the hospital and community. And we also are thinking of what we call entry or re-entry points, or rather step up or step down care depending on the needs. So for example, if a patient has done hip fracture surgery and we feel that they are okay to go for rehabilitation service, we want to be able to move them to another center for rehabilitation, or if they get unwell and they need to be stepped up to the acute hospital, that they can do it. So, and we want to integrate secondary fracture prevention into the hip fracture license fracture service program. And what are the criteria for a fracture license service ready hospital? It's pretty simple actually. We just want an MOH hospital with emergency department, orthopedic surgery, internal medicine, anesthesiology, radiology, pharmacy, and physiotherapy. So that's the minimum. And for the patients, we are thinking of involving patients aged 60 years old and above, and who has had a fracture within 6 weeks of presentation to the emergency department. And for fragility fractures, we wanted to propose that we want to include patients 60-year-olds above for all fragility fractures. And at the very minimum, these are the requirements for a facility to implement a GFLS program. Basically, you need to have a ward, an OT, an adequate rehabilitation area, and a clinic. And you also need to have X-ray and image intensifier in the OD and ambulation aids. And you need to have the implants for hip fracture fixation. And you need to have access to osteoporosis medication. But an ideal service will comprise of so many more components, right? Like rehab medicine, dental surgery, OT, geriatric care, and so on. And of course, in terms of infrastructure, they will also have a more dedicated area for closer observation for patients who need a higher degree of monitoring, and also machines that will help us to diagnose patients should there be more uncertainty as to whether they have fractures or not, and also better pain control services. And so in terms of the fracture license service, we are spanning the whole continuum of patient care, right from the acute admission itself, all the way to the pre-operative to post-operative phase, all the way to the rehabilitation phase, and then to preventive care. So of note here, I just want to point out a few things. Number one is that when we talk about rehabilitation, we are not talking about just inpatient rehabilitation in the initial hospital, which is what we call rehab tier 1. We are also thinking of inpatient rehabilitation by transitioning to a cluster hospital for patients who need longer term rehabilitation. And we do have some of these service right now, or when I was in Taipei, it was there, where after an acute hip fracture care, we send patients to Kuala Kangsar for longer term rehab. And we also have tier 3 rehab, which is outpatient rehab. So we are not limiting the rehab to the inpatient. It depends on the patient and the suitability. And another thing that I want to mention here is in the community level. When we're talking about community level, we're talking about preventive care, osteoporosis, falls and fracture prevention. And who are the people who can institute this? Well, we are thinking of multiple stakeholders actually. It could be the internal medicine physician, it could be the geriatrician, it could be the orthopedic surgeon, or it could even be the family medicine physician. But when you consider the scope of the things that we need to do, which not just encompasses osteoporosis management, but also falls and fracture prevention, the right people to do that would probably be either the geriatrician or the internal medicine physician or the family medicine physician when we're talking about just both these continuum. And we have defined roles for all these members of the multidisciplinary team. But I think over here, we are chiefly interested in the role of the internal medicine doctor and the geriatric medicine doctor. So why am I talking about the role of the geriatric medicine doctor? As it is, we do not have enough geriatricians in the Ministry of Health to actually run this service in all the different centers where we want to run this service at. And so there is a need for the internal medicine doctors to step up to take over where we are not able to get direct access to a geriatrician. The role of the internal medicine physician is, simply put, just to stabilize the acute medical conditions, to manage the medical comorbidities, and to screen and manage for delirium, and finally to optimize the bone health. But in centers where the geriatricians are not around, they will have to take up some of the roles of the geriatrician, and that would be a bit more extensive. So that includes, managing the cognition, nutritional status, functional status, and complications, and also to plan the rehabilitation and to evaluate false risks. Not necessarily all these components, but some of them are very important. That is false risk evaluation. That's something that the internal medicine physician probably need to do as with rehabilitation as well. They will need to be involved in terms of the care, if not as the main person, but as a supporting person. And so how we envision the physician, the role that the physician will take in the geriatric fracture license service. This is not our flowchart. This is from Hong Kong, acute and rehabilitation hospital. But basically, it is highlighted in blue, the roles of the geriatrician. The internal medicine physician during the acute phase will probably be focusing on managing medical complications like pneumonia or heart failure, and acute issues such as unstable cardiopulmonary state or delirium, and then also to institute osteoporosis and falls prevention, and help to facilitate for discharge planning and also medication adjustment and review. And this role of liaising with the community and physiotherapy can be taken by any other members of the team, not exclusively physicians. But because our services are usually engaged throughout the whole continuum, right, of the patient care for an acute hip fracture, we usually end up being the ones that unify all these roles. And so this is how we envision it, in this service, for example, it is done through joint rounds 3 times a week. So we're not saying that you have to do your rounds every week, but at least you need to be able to cover patients. You co-manage with the surgeons, screen for high-risk patients for stabilization, plan for medical treatment, manage the acute delirium, manage polypharmacy, and also co-manage osteoporosis with the rehab, with the orthopedic surgeon, and co-manage the medical problems, as well as to follow up and help to arrange for a proper and appropriate discharge planning with further secondary fracture prevention, perhaps in collaboration with the primary care physician. And physicians may also, if this policy gets implemented, be involved in the governance, probably in the facility level, in terms of the facility committee, because if this becomes a key performance indicator for the hospital administrators, they will have a lot of interest to get this right And so internal medicine physician will be vital there. And perhaps that will also be involved in the state level as a state champion. And in the national level, the heads of departments, as well as the steering committee members, elected steering committee members will be involved. And this is what we propose as the key performance indicator to start off with. Number one is that we want to reach the proportion of 50% patients operated within 48 hours with reasonable exclusion of patient refusal, medically unfit, or other extraordinary circumstances. And we also want to have about 75% of patients discharged to go back with osteoporosis treatment. If you remember, when I talk about the when we talk about the percentage of patients who persist on osteoporosis treatment, right? We get that, even after we start the treatment, not only a proportion of them will stay on the treatment for as long 1 year or even longer after we start their treatment. So that's a different one. So the third one is investigation for secondary osteoporosis risk factors. And the fourth one is false risk factor assessment. And the fifth one is to make sure that there's adequate perioperative pain management with pain score of less than 4. This is in line with our pain-free hospital policy, so it's nothing different from that. And also post-operative ambulation. We want patients to be able to ambulate unassisted before discharge, assisted before discharge with a walking aid if possible. And actually, when it comes to implementing a policy, we do need to propose for data to be collected, because this will then be our vital sign to tell us whether we are going the right direction with the service. And although it seems like there's lots of things that we are looking at here, it will not be done just by the physician alone, and it will be a collaborative effort. And bearing in mind that the main person is still and the process of data collection will, of course, have to be discussed between the respective centers as to how it is to be done. And so that is actually the policy. That's a very short talk. And in summary, well, falls and fractures are prevalent in older adults, and they cause significant morbidity and mortality. And those older adults present with hip fractures as some of the frailest, sickest patients you encounter. And that is why we need a multidisciplinary holistic approach to treat these geriatric fractures. And this is an approach that existing models of care are not ideal to tackle. And given the aging population, it is quite timely to introduce a national policy on management of geriatric fractures. And so GFLS is a multidisciplinary system approach to manage fragility fractures. And we aim to reduce morbidity, mortality, and prevent future fractures. And it's based on these pillars of orthogeriatrics, what we call multidisciplinary acute care, rehabilitation, secondary fracture prevention, and it needs to be supported with national alliances and policies. So why does policy matter? Because it allows standardization of care, efficient resource allocation, interdisciplinary collaboration, and it empowers stakeholders with opportunities, resources, and knowledge. And over here, the role of the general physician and geriatrician is integral, because they are involved in all stages of care, from admission to rehabilitation to prevention. And that's it for my presentation. Sure, there may be some questions that you want to ask, so we'll go on to Q&A.
Thank you, Dr. Lim. While I'm waiting for more questions to come in, I just have one question. It's a very good talk, a bit overwhelming if I'm a physician looking at the list, so long. So we as physicians, we have always been referred to see patients pre-operatively. Would you want to tell me a couple or 3 things that I should focus on? How is it different to any of my usual referrals, pre-op assessment thing? Is there any particular thing you think I should focus on, and what is the reason for it?
As opposed to, let's say, any of these usual referrals where you may get referrals of orthopedic work for particular reasons, like, for example, patients have atrial fibrillation or they've got anticoagulation. It may be good to approach these patients in terms of by getting a little bit more information on what their premorbid function and mobility is, and get a more overall comprehensive view of what their premorbids are like. Okay, so basically it means that when a patient presents with a fracture or fall, it is usually a marker that there's something wrong with the patient, right? Because they won't fall without any reason. And that when the referral is crafted in such a way that you are supposed to focus on the acute problem, you also want to look at the reasons why patients have fallen. And some of these reasons may be very obvious and staring in your face. For example, it may be some medication that need to be adjusted, and that needs to be looked at also, not just whether they are bleeding or they have atrial fibrillation. And it is good to know their functional status as well, because it ultimately guides us on what we might want to do at later stages. So, and another thing is, given that they have vulnerability, and given that one of our role is to assess for delirium, right? It's also good to screen for delirium by looking at the cognition. Yeah. I'm trying to think of a way to make it sound simpler, you see. So, but it ended up being so wordy and lengthy. But basically, screen for delirium, look at their medication, and find out their functional status and a little bit of their social history, not just solve the problem that is presented to you by the surgeon.
Okay, talking about that medication you were talking about. So what about outpatients? A lot of times, we don't get to see them as inpatient, and then they refer to us like outpatient had a fracture already, multiple comorbids. And the orthopedic team do not initiate any protection for bone in terms of management of osteoporosis. Do you think a physician should be initiating the treatment? Or even if I'm a primary care physician, should I be initiating it? And what other things should I look at after this patient has a fracture in outpatient?
Well, if a patient has already had a fracture in outpatient and you see that patients are not being treated adequately, I think that regardless of whether you are internal medicine physician, you're a primary care doctor, you're an orthopedic surgeon, I think I would like to say that you should initiate it. If you are thinking of whether fractures or osteoporosis care is the domain of certain specialties or certain doctors, I think you'll find that you are in a no man's land, that everyone can manage it. And because everyone can manage it, everyone thinks that other people should manage it. So I think that doesn't do the patient any good. And if you find the opportunity to do so, you should do so. But it's not just osteoporosis treatment, of course. You also need to do false assessment. And this is where there's a little bit of difference between the different specialties. An orthopedic surgeon may not be as well equipped as, for example, a geriatrician when it comes to false assessment. And of course, in terms of internal medicine doctors, not many of us actually have an idea of how to institute false assessment. But I think this is something that we can train, and perhaps with a little bit of support, right, from the higher ups. I do believe that internal medicine doctors or even family medicine doctors are able to will be able to perform false assessments. And how we do it in the practical sense is by the use of checklists. Checklists are useful, especially for those who are less familiar with how to perform it. And of course, if there's an opportunity, training, we'll be able to teach physicians and equip them how to do false assessment.
Okay, as it is, we have also asked for approval for the Ministry of Health for primary care physicians, family medicine specialists to initiate osteoporosis medication. So you can initiate bisphosphonate in primary care. And of course, if you're in a hospital, you are encouraged actually to prescribe, because you are allowed to ask through J-code or KPK for osteoporotic medication. Moving on to the next question, what would be the best assessment tool of falls to be used in primary care? Because our time given is very short in our clinic.
Well, in terms of the best tool, I guess we will just have to look at what may be center specific. But if you're talking about easily available tools out there for you, the CDC Steady initiative is a very accessible one. In fact, Dr. Nagamai has asked before, and I've also recommended that we use it as a starting point. But there's nothing stopping you from developing this checklist that you get from these standardized CDC initiatives and all that to become specific to your own center, right? And if you should need help to develop a more customized sort of false assessment procedure or checklist, I believe there are people out there who can already help you. In primary care, we have Dr. Nagamai, and any of us geriatricians can be contacted to help you to craft customize this.
Well, Zuraini, very sorry. Of course, as geriatrician, there's so few of us. The first thing that we have developed in terms of falls is always inpatient. So the module is up for inpatient. We are in progress doing the modules for outpatient. Actually, as we speak now, we've done doing the webinar series for the first cluster, which is Cluster Titi Bangsa, who are now 4 of the KKs are coming together in KKL, having their seminar, which is a 3-session over 3 months on training on falls and osteoporosis. So this is a pilot project. Once it's gone through, we'll be writing up more specific modules for all the clinic kesihatan. I understand the frustration as well, because sometimes you're out there, you don't know where to find all these materials. It is in progress, but at the moment, like what Dr. Lim said, internationally, there are a lot of good guidelines, like the CDC study. They are very useful, and we hope that you can use that at the interim. And you will see more clusters starting to have what you call training for their cluster, because now clusters of KK is clustering with hospitals, learning how to do falls and osteoporosis management, because this is part of the new initiative of Ministry of Health. Okay, I think we don't have many more questions here. Just want to ask Dr. Lim a last question. If we want to learn more about falls and osteoporosis or about FLS, is there any special place that we could learn from?
Well, we do have these webinars that the Fragility Fracture Network of Malaysia have created and designed. You can go there as a starting place. And just like I was talking about the CDC as well, like Steady Initiative, right? You can also go there and have a look. As for other existing falls assessment tools, perhaps for the physician, they may be interested to know that we also have some falls assessment guidelines, right? But basically, these are patient safety goals. Is unrelated, but there's also documents there already about falls assessments that you can also refer to.
Okay, so just to reiterate what Dr. Lim has said, there is a society called Fragility Fracture Network Malaysia. So if you can just Google it, there'll be a lot of information in there. And there are also modules written for FLS management, which you can write in and they'll send you the link to join us. There are 7 lectures in there and you get CPD points if you join them. And number 2, I just want to do some advertisement. Please come and join us in our conference that we hold yearly. And this year, the conference is packed with the ASEAN Falls Network. So it will be September 12 to 13. So once again, you can just Google and do come and join us. It's good to listen to the experts in the ASEAN country. Some are better than us, obviously. Let's say Singapore and Thailand, probably lots to learn from. And we also have poorer countries who will share to us how they did their falls. For example, Vietnam, Laos, and all that, just to see how with minimal amount of money they can run their fall service and FLS. So I think it's a very good webinar to come and share information about. A lot of times we go to international conferences, you just think, oh, it doesn't apply to Malaysia. I mean, 50 years ahead of us and stuff like that. Totally understand that. But now we got ASEAN to come together and we help each other out. To be very honest, Malaysia is doing very well in terms of FLS. So Malaysia is also tasked to help other countries. So at the moment, we're helping countries like Indonesia, Pakistan, to help them set up FLS services, because we have tried with minimal amount of money and well. So we are helping our neighboring countries. So we do hope that more of you can come and join us, because you cannot escape. Because if it becomes a policy, a physician will be referred a case of fracture. I just have a colleague from Kajang calling me, oh, what on earth is this about, So I sent her all the guidelines and guide her. So do contact us. We are so many geriatricians around, 40 of us in KKM or so many of us in private. Do ask us the questions that you need to know. We will try our best to help you in your day-to-day management. I tell you how beautiful this FLS work, okay? If you come in with a fracture, maybe in your 80s, with multiple comorbids on Monday, by Wednesday, you'll be operated on, because there's part of initiative to operate you within 48 hours. No traction, lovely pain relief, including a block. You're nicely sitting in your bed, you have the operation. By Friday, you'll be walking home. So we got this patient, within 2 weeks, she went back to line dancing, as if nothing has happened to her. Would you not want that to happen to your grandma, your parents, or even yourself, those who are aging? So it's a very beautiful initiative. It's called Short to Operation Time, Minimal Deconditioning, and Prevent Complications. So I hope all of you hope that you're all on the same line with us to make sure this initiative happen in Malaysia. If it's not for our ancestors, it's for ourselves. In future, if we have a hip fracture, we want to be back to who we are. Thank you very much. I'll pass the time back to Kelvin.
All right. Thank you, Dr. Elizabeth, for chairing the session. And thank you, Dr. Lim, for the wonderful talk. Thank you, everyone, for participating in our webinar today. We will see you guys next week. Bye-bye.
Thank you, everyone.